Exactly. And yes. You have to be here early. Is it okay?
Yes, sir. Absolutely.
The dignitaries on the dais, my colleagues and younger friends. You might have heard me on this very subject many a times, but probably the millennial generation might be listening to me for the first time. I couldn't attend a few years conferences, so I have a privilege to be able to address to the younger generation. Tuberculosis has existed with human beings since the arrival of man on Mother Earth. It has not vanished. It is still there. So long as there are pockets of poverty and deprivation in the world, tuberculosis will keep on existing. Are subjected to deprivation either through human calamities or by natural calamities. Tuberculosis of the spine, of course, is the commonest tuberculosis of the vertebral of the skeletal system. And this is the pathological specimen which I picked up from Medical College, Patna. You can see the curvature has taken place, and it also shows you a classical paradiscal lesion. There's a destruction. Bones have probably vanished. The cartilage may be still hanging around, and there's a deformity. Despite so much of destruction of the bone, the dural tube has not penetrated, and probably the underlying structure, the underlying contents of the dural tube are still intact. And this is the X-ray of the same specimen. Even if there is a horrifying specimen, the dural tube contents are. And that is what gives you an opportunity to the bright possibility of neural recovery in tuberculous paraplegia. Paraplegia occurs due to many reasons, but tuberculous pathology causing paraplegia has the brightest chances of recovery. This is how tuberculosis was in the world. It came down to this level much before anti-TB drugs were available. Let us say this is from European countries. As the socio-economic status of the country and the population increased, tuberculosis disappeared or came almost to this level. BCG chemotherapy came at this stage. But today again, there is a tendency for it to go up because there is a change in the human dynamics. We are living for a longer time. We are permitting diabetes people to survive. We are using steroids for treatment of many conditions, and especially organ transplants do need corticosteroids. Once you put these patients on corticosteroids, the immunity comes down and there are chances for you to get tuberculosis. In the recent past, some beautiful investigations have. One of them is isotope bone scan, which can show us many more lesions than is isolated suspected lesion. There's a son of a doctor. He came to me with this one. I said, probably it's a tuberculosis disease. If possible, let's have a CT scan done. We didn't have the CT scan. He went in for an isotope bone scan, and you can see, in addition to one lesion which is visible to us, the patient also had a destructive lesion in the sacrum. In fact, if every patient of spinal tuberculosis presenting to you could be subjected to a generalized scan, probably 40% of them will show you another subclinical lesion in the body, which shows us the thought about treatment. If it's an isolated lesion, people keep on talking about excisional surgery. But if we know that 40% of people have more than one lesion, which may not be visible to us, a local surgery is not going to eliminate the disease. You will have to give systemic therapy to continue the treatment. Here is an example of compromised cell immunity giving rise to a disseminated tuberculosis. The patient was on steroids for a pancreatic problem, and the patient comes to us with tuberculosis all over the body, almost all over the body. Here are both the tibia showing tuberculosis, spine showing tuberculosis, ribs showing tuberculosis, and the humerus showing tuberculosis. Basically, if there is a gross diminution of the immunity, the patient is likely to get many more complications. Today, we have the facilities. We shouldn't wait for a gross destruction and a huge swelling to make a diagnosis of TB. Today, we have the facilities. You can make them at a pre-destructive stage. Here is MRI available to us. Sacral tuberculosis was not easily diagnosed on plain X-rays. And here is a pre-sacral abscess, which again was not even imaginable before the availability of the CT scan and MRI. And these were the difficult areas: cervico-dorsal junction showing destruction and cold abscess, sacroiliac joint also showing collection of cold abscess. These things were not possible before the availability of the MRI and CT scans. Despite all that, what looks like tuberculosis may not be tuberculosis. I keep on repeating ad nauseum, tuberculosis can mimic any disease and any pathology can mimic tuberculosis. Tuberculosis is a great mimic so long as we are depending upon clinical, radiological, imaging modalities. And when in doubt, you must obtain the tissue. What do you do to the tissue? As students, we must know that tissue must be subjected, 1, to histology, 2, to microbiology, 3, to serology. You have 3 tests available today, and we should take the help of all the 3. Does it give us 100% information with these tests? No. There will be 20% of patients in whom, despite histology, microbiology, serology, you will not know the diagnosis. And that is where lies the prominence of your clinical judgment. There are many patients in whom one may have to depend only on clinical judgment, having put in all the efforts. Here is an example, what looked like a perivertebral abscess, cervico-dorsal junction. It turned out to be a chondro. It turned out to be a chordoma. Here is a collection. Here is a collection, destruction, which turned out to be myeloma, turned out to be an Ewing sarcoma. Another example, myeloma, tuberculosis, Ewing sarcoma. Collection around the vertebral body, probably lumbar 4 vertebral body, and it turned out to be a round cell carcinoma. Treat these patients fine, but keep a close observation. And when in doubt, you must subject them to a tissue diagnosis. And as I mentioned earlier, today's physician must not wait for such a huge abscess or destruction to make a diagnosis. We should be able to make a diagnosis much before the destructive phase. Here is a huge prevertebral abscess, suspectedly in here. Again, for the students, the size of the abscess does not necessarily correspond to the destruction of the underlying bone. The abscess may be small, the destruction may be much more, and vice versa. The abscess may be huge abscess, but the bone destruction may be minimal. And if you diagnose these patients, treat them well, the person may heal without leaving behind any deformity. Here's an example of the use of anti-TB drugs. Look at the destroyed vertebral bodies and an abscess, everything healed by giving anti-TB drugs without any operative intervention. As a psoas sepsis, here's an example. If you diagnose them in time, before gross destruction, treat them well, the wound, everything will heal with leaving behind small diminution of the disc space. The healing may take place by three methods. It may still maintain as a thin disc, or it may get replaced by bone, so-called osseous healing. So there can be a fibrous healing, there can be an osseous healing, and there can be a mixed healing. When MRI came, MRI was very useful. When MRI came, there was a panic. MRI at presentation and MRI at 5 months. It seems that the abnormal area has increased. Look at this one. And there was suggestion that we should go in, operate. It is non-responding. However, gradually we learned at around 5 months, the healing process has already started. And the healing process is going to be basically vascular granulation tissue. So the vascular granulation tissue will start healing the disease from these areas, from the adjacent healthy areas. And that is what gave us an increased involvement impression in the MRI at 5 months. Look at the same patient, goes back, and you can see it is healed. The MRI inflamed area has resolved on its own. So one should, as a student, we should know, don't get upset between 4 and 5 months if the MRI shows an increased area of inflammatory changes. There's the same patient being shown at the time of presentation, and this is after roughly 1 year after the treatment without any surgical intervention. Again, showing the same thing, that the diseased area, and during follow-up, look at the whole inflamed area seems to have increased, which in reality is not the disease which has increased. The area of vascularity has increased because reparative process is a vascular granulation tissue. And here is at the time of presentation, and this is a bone block formation, healing by bone block formation. Sometimes the bone may be replaced, not the cartilage, but the bone can be replaced by fat. Sometimes it does happen. This is also one of the methods of healing, bone fat replacement of the bone, and it will keep on showing. Fat will be white both in T1 as well as in T2. Here is a process that the bone has healed by a bone block formation. Here it has healed, but the disc is still visible. This is fibro-osseous healing. This is fibrous healing. This is a bony healing. Here is a cold abscess around the upper part of the dorsal spine, and this is again healed by anti-TB drugs, relative rest, supportive therapy. Roughly 10% of people which come to our country for TB of the spine will get tuberculous paraplegia. Tuberculous paraplegia has been classified as stage 1, 2, 3, 4. Stage 1, patient is unaware, but the physician detects the plantar extensors and ankle clonus. Phase 4 is the worst one, whereas the patient gets into flexor spasm, flaccidity, sensory loss, and sphincter loss. So we should be able to make a diagnosis at this stage, and majority of the patient, if you treat them as stage 1, majority of these patients will recover by suitable rest and anti-TB drugs. Whereas most of the patients at stage 4 or 3 would need surgical intervention. When paraplegia occurs, most of the pressure takes place in front. That is why motor symptoms occur first. It is the motor symptoms which bring the patient to you, that he is not able to walk, or he has got clonus, or he gets jumpiness while walking. Motor symptoms occur because most of the disease in tuberculosis is in front of the dural tube, and the pressure is on the anterior structures. Sense of vibration and sense of position is the last to go, because they are in the posterior columns. And when recovery takes place, the faculties which are last to go are the first to come back. The faculties which are the first to go are the last to recover. Classification of what is the pathology behind neural complication? Inflammatory cause, mechanical cause, intrinsic cause, combination. If you can make a diagnosis at inflammatory stage, it is edema, granulation tissue abscess. They have a brilliant chance of recovery by anti-TB drugs and rest. Here is an example. This is a myelogram done. There was a time when MRI was not available, and a myelogram used to be done by us, our physicians. Here is a patient who has a tuberculosis disease visible in the X-ray. Myelogram shows a block. Patient is paralyzed, and we have to operate. The patient's condition is so poor that you cannot operate. Put the patient on rest, put him on anti-TB drug. We are waiting for the patient to be fit for surgery, and in the meantime, the patient starts showing recovery. And to our pleasant surprise, you can find that the myelogram, which showed a block, has recovered. The block has resolved, and the myelogram is showing myodil going toward the proximal side. So we were ready for surgery, but the patient was not fit for surgery. During that waiting time, the edema subsided and myodil started moving proximally. Here is another example: cold abscess, paraplegia, anti-TB drugs, and recover. These are in the cervical spine. You can see the cord almost compressed to a small crescent. Cold abscess, paraplegia, recovered. Here is the restoration of the spinal canal or spinal cord. Another example, here is the spinal cord pressed by the tuberculous abscess from behind, posterior disease, but anti-TB drugs, rest, and you can see restoration of the canal, spinal canal, and the healthy spinal cord. In the main indications for various operations for the vertebral tuberculosis are following. If the patient comes to you without neural complications, 95% of them would heal by anti-TB drugs. Whereas if a patient comes to you with neural signs, roughly 30% of them will require a decompressive surgery. And these are the indications: neural complication, failure to respond, doubtful diagnosis, mechanical instability, recurrence of disease, prevention of severe kyphotic deformity. And sometimes you will require anterior transposition of the cord through extrapleural approach. I think the time is getting short. This for the cervical spine. The best approach for cervical spine is go from front. This is the simplest approach for the cervical spine between the median structures and the carotid sheath. This is a classical anterolateral decompression done for the dorsal spine. You remove the transverse process, rib, and you reach the vertebral body, and you can do the decompression of the dural tube. Here are the examples: dural tube decompressed, bone graft put in around the spinous process, and the healing taking place. Another example, bone graft put in here. Here is a bone graft which has healed. This is the operated side. 2 ribs or 3 ribs are removed, and then the healing taken place by a bone block formation. This is for the lumbar area. There are no ribs, but you can remove the transverse process, go to the base of the transverse process, you can enter into the vertebral body and remove the offending tissues. Rarely, even after doing a decompression, a patient may not recover because of syringomyelia taking place or myelomalacia taking place in the cord. Roughly 7% of patients, despite effective decompression, in a case of tuberculous paraplegia, do not recover. Recently, there is enthusiasm of putting in metal in the infected area. Encouraging. Here is a patient in whom the fixation has been done with metal on the infected bones, and the infected bone has been draining out pus for many months. Here are the screws, and here is the pus coming out for many months. Ultimately, even the removal of these screws are very difficult, are very dangerous in these patients. Here is another example, dorsal-lumbar tuberculosis. Fixation has been done with the hope of stabilizing, but look at the pathological fracture that has taken place and a dislocation has taken place. And here is the patient, a young lady. This is the disease area, dislocation, subluxation, scars, and still draining pus, and she's in a catheter, and she's a non-walker for the whole of her life. And here is an example of a classical tuberculous lesion, perivertebral abscess, and recovers within 1 year of their treatment. Is the same patient radiologically at the time of presentation, and this is the final healing that has taken place without any surgical intervention. This is what has to be avoided. If we are careful about it, I think if we can make a diagnosis in a pre-destructive stage, you should not expect this sort of deformity. And approximately 3% of patients in our country come to you with this deformity. I think this is preventable. I will just tell you what is the spine at risk for severe deformity. If we can know this thing, if the patient's age is less than 11 years, disease occurs between C7 to L1, vertebral body destruction is of 3 or more vertebral bodies, there are chances that the patient may develop severe kyphotic deformity. Loss of vertical height is more than 1.5 vertebral bodies. Again, there are chances that the patient may develop severe kyphotic deformity. Otherwise, you're obliged to have a look. You're obliged to have a look on these patients, have a look on them again and again, follow them up. If there is a deterioration of the kyphotic deformity in successive X-rays, one should do a posterior fusion to minimize the chances of increasing the deformity. I just want to show you this slide. There are 2 vertebrae involved in a growing child and healed like this. These are 2 vertebrae. We learn to count that this block belongs to 2 vertebrae if you look at the pedicles at the back. That is one indicator which tells you when you operate upon a child, be careful. It is not necessary to remove the whole of the bone. Remove only the offending bone, because these bones in a child may still maintain a growth potential. And you can see this bone has become this bone with the growth of the child. They maintain a potential for growth for a very long time. I think I'll just close it. Let's not forget the basic pathology behind tuberculosis of the spine. And this specimen shows us that for a very long time, the dural tube and its content remain healthy, they can be taken care of by drugs alone. I think operative intervention should be kept for non-recovering neural complications or for patients in whom you are expecting a severe kyphotic deformity. Thank you, sir.